Well, first, I do receive research grant support from Alcon, but it has no relevance. And I take this opportunity to wish all of you here who are listening very happy Independence Day. And we are so proud of our Jawans that doing all the hard work for us and sacrifices. But the key is this AIOS, and I've seen the change since Namrata Sharma, the secretary, and her entire team has taken over. So much of education and real education I've never seen anywhere else in my rather long career. So congratulations, Namrata, and the entire AOS team, scientific committee, and everybody, who really has changed, and then people have started recognizing and attending AIOS webinars from all over the corners. So Namrata and the team, thank you so very much.
Thank you, sir.
Now, this is a rather familiar situation, and once this happens, you know what the feeling you have, and your heart is in the mouth, and you really stop decerebrated, your higher control disappears. And that's where the moment of truth comes, actually. And then we have had a traditional way of management, and over the years, many experts have told me and many others that we need to think a little differently and take a path which has not been taken up by cataract surgeon when you find an unforeseen or a planned situation where you need to address the vitreous in the area of the cataract surgeon. Now, I'm going to address this problem mainly related to the capsule rupture. So I'm going to limit or sort of mainly focus on the need for vitrectomy during the cataract surgery, primary cataract surgery. However, we realize that for secondary IOL implantation, also we have a situation, but for the secondary IOL implantation, I believe we need to have a co-management with retinal colleague, but that's a different topic altogether. So when the posterior capsule rupture, first thing is to keep very calm, and obviously you don't have to panic. What I do is I stand up from my chair, and my assistant understands and gets the vitrectomy ready and fix it up, and I sit back again on my chair. I reset the PD, which was actually all right, but I redo it again and tell myself, this is a situation, stand by my friend, how can I help him? So that mental approach is very important so that you can understand what's happening. And first thing is to keep the instrument inside the eye and inject, I believe, viscoat. And that also will create a barrier effect on the exposed vitreous, but it will prevent the forward bulge of that. You can use methyl cellulose. I would recommend viscoat because viscoat, methyl cellulose, and the cellulose of it, the vitreous can produce vitreitis. So even if you're not using chondroitin sulfate, use chondroitin sulfate. And once you do that, you have a time now. Extent of the PCR, identify, and then backup strategy. And in these modern times, we always should have a backup 3-piece and various other options of your choice. So here we are. We have a PCR, and we are injecting triamcinolone. And then thanks to this triamcinolone, which stains the vitreous after assessing the extent of the PCR, that will allow us to identify the presence of it into our field. And triamcinolone can be used in pediatric cataract surgery as a routine where we have to open up the capsule anyway. But the key is that really this is the great stuff, and those who are not using it, please keep that ready always in the theater, and you can be embarrassed by seeing weak of vitreous going to the incision, however small or big.
When the vitreous face is disrupted and only part of it is removed, the symmetry of the vitreous scaffold is disturbed.
So you need to identify that vitreous there. And having done that, I'm taking that picture again, the one I started with, and I'm doing that staining again. And now I have an option of doing the pars plana. So what I'm doing is making a pars plana entry. I'll come back to it, how you make it, but just to illustrate that, see that the vitreous is being drained into the retractor without disturbing the posterior capsule tear or anterior chamber. It's very tranquil, and the vitreous will simply be drained through that rupture, and the area of the work will be vitreous free. So pars plana allows us to do that very predictably and in a controlled manner. And then you can have a strategy of removing the remaining matter, and then you have a choice. You can lift these fragments up in the anterior chamber or use various supporting devices, but I don't recommend that. If you're doing a good vitrectomy, vitreous is not in your area, and you can use the low parameters. And you notice that I'm using 12 cc flow rate instead of 25, 30, 35, and sufficient vacuum, but more energy. And I'm removing the same eye here with fragment, and I'm not worried about vitreous coming in. My bevel is actually facing down to avoid the endothelium. If you see my bevel, I'm trying to keep it away. So the point is that if the vitreous is not in the area of the cataract surgeon, you can remove these fragments with low parameters and low input. Before we get into this, let's understand some of the basics of anatomy of the vitreous and the eye. This is the pars plicator region and pars plana. Both are ciliary body. And then the ora serrata comes. Now this is very important. And there are different opinions about it, but pars plicator extend up to 2 millimeter, and then up to 4 is pars plana. So entire ciliary body of pars plana and plicator is 4 millimeters. So ideal would be to avoid plicator as an entry point for sutures or for vitrectomy, and retinal surgeons recommend 3.5 millimeter, but that can be anything from 3 to 4, but certainly in that region that you want to enter, even for intravitreal injection, aiming that, and I'll come to that later on. So that's very important because we want not to go forward, not to go too much posterior. And that's what Dr. Samresh Srivastav showed me in his Miyake review, that if you're 1 millimeter or 1.5, you can actually be very close to the zonular apparatus or to the plicator. So that you need to keep in mind. And instead, if you are in 2 millimeter zone, you are at the border of the plicator and pars plana, and then you're relatively not injuring this highly immune-rich uveal tissue in the plicator region. And this is Jan talking to us about various spaces and various septa, and they are very important for a cataract surgeon. And this is the animation Dr. Shettle made it for me, and these are all tracks attached on the base and on the posterior segment. And see what happens. This is the anticapsule tear, and with continuous phacoemulsification, the tear extends around the equator, and the lens starts sinking. Now, because you can see that it is within your reach, and you think I can grab it with or forceps or even a vitrectomy to limbal root. But that's dangerous because, as you can see here, with that movement, the vitreous is prolapsing, but there is a traction coming here and there. So remember this diagram, and you will see a giant tear being initiated and a macular traction. So do not place any instrument, lavaging, for example, which was suggested by Dr. Kellman, with all due respect, is quite dangerous. So instead, say bye-bye, and this is a goodbye technique. Let it sink, because you can see that these tracks, if you remove this nucleus, which is surrounded by vitreous, you will produce a lot of traction there. These are the tracks Jan was described, and anything trying to grab this with anywhere, whether it is in the anterior chamber, anterior vitreous, or mid vitreous, you are inviting trouble and producing vitreoretinal traction. So I would recommend just let it go. Dr. Shamare Srivastava also showed on an award-winning video what happens as a cataract surgeon when you use a lot of high parameters, high bottle height and high aspiration flow. This is a cadaver eye, not necessarily happening in the live human eye, but it is a possibility in some eyes. Irrigation on and off, and the entire vitreous face, intact capsule is moving forward and backward. Now we increase the bottle height and the flow rate from 20 to 40 cc flow rate and see what happens. Still the posterior capsule is intact. Posterior capsule is not ruptured, but see the movement of the entire capsule and antivitreous diaphragm. The injector triamcinolone in the anterior chamber, and through the intact capsule, the triamcinolone leaked into the vitreous. So the point is that high turbulence and high fluctuation can increase the permeability of the capsule diaphragm and can leak out, and maybe this is one of the reasons for cystoid macular edema. But vitreous physiologists have told me that it is an increased risk, oxidative stress on the trabecular endothelial meshwork if the anterior vitreous face is disrupted. So whatever we do, we don't want to do that. But here is a situation where it is disrupted. So what is the goal of vitrectomy? First of all, you need to do vitrectomy. We must understand. You cannot shy away, inject air, and then close the eye. As I have done in my early 70s in my housemanship in Baroda. Don't do that. Always perform vitrectomy. And what is the goal of vitrectomy? The primary goal, if I have to single out one aim, it is preventing intraoperative acute vitreoretinal traction. That's your main aim, not to salvage the sinking lens material anyhow. Let it drop. As a cataract surgeon, your aim is not to keep the lens material in the anterior chamber anyhow. Don't do that. Just let it go. So other aims and benefits is that if you do vitrectomy properly in a right way, you can prevent further enlargement of PCR, and therefore you can put the lens in the bag in some cases. And also will allow you to remove the vitreous very adequately, provided you produce a symmetric, uniform removal of the vitreous. You can support the IOL into using that support. But whatever method you do, Limbal, pars plana, please and please do not perform dry vitrectomy. Hypotony is lethal. Please never perform sponge vitrectomy or a cotton swab and so on with the scissors, because Steve Charles, with whom I do the course in various mechanics, taught me that will produce acute intraoperative vitreoretinal traction. So you can have a choice, and you can do Limbal or pars plana. Nothing is wrong with any of these, but let's understand what happens with what. Before we do that, when do I do vitrectomy? Anytime, earliest.
Here's another case. We encountered a PCR early in the...
Anytime when you encounter the vitreous. Here is a case in the beginning, it's very end, somewhere midway, but this is interesting. A mature cataract with zone urodialysis never known that vitreous. Now, what do you do with mature cataract? First, so we will come to that, but anytime, whenever you see vitreous disturbance, you need to address it before you perform the cataract surgery. And you have this Limbal approach, which is very good and has served us for many years, and has done quite a decent job. Make sure that you go right into the incision, sub-incisional to prevent incarceration when you perform that. And it's always triamcinolone, as we showed earlier. So Limbal approach has appeal. It is a very familiar territory for many senior surgeons. Those who are in the beginning may not be, and therefore has become a routine. Like iridectomy was a routine when I was doing the cataract surgery in early 70s. So it has become a routine to perform a Limbal vitrectomy, and that's fair enough. However, the problem is that now we understand that it causes more intraoperative traction on the vitreoretinal interface than the other approach. And typically, posterior capsule, which is small, typically enlarges moment you start vitrectomy and the fragments sink, posterior segment. And therefore, some people use, and Priya would tell more about it on the scaffold technique and so on, but that's because the limbal approach of vitrectomy, those vitreous is removed and then the lens fragment is not supported and then sinks. And therefore, primary objective of IOL in the bag placement may not be achieved with this technique, but not necessarily. And Samresh once again showed us beautifully in his wool experiment what can happen to the tear when you drag the vitreous from top to bottom, from anterior to posterior, typically tear enlarges. And he once again showed and published this slow motion technique of what a turbulence is produced when you do limbal vitrectomy, particularly if you go through that tear to achieve that anterior vitrectomy, anterior vitreous removal, and that vitreous is dragged forward and will enlarge the tear straight away. So this is the consequences of limbal approach, but that still is a viable option, and continue doing it until you master the pars plana approach. But this is something you all should aim to perform one day if you're not doing already. And that's because the traction is minimal on the vitreoretinal interface during the surgery, and therefore the consequences are minimal. And the enlargement of the posterior capsule tear is minimized, and more adequate or thorough vitrectomy is possible. However, it is not a familiar territory. We have never seen in the training, or it appears rather intimidating. And many people think that it needs the elaborate setup and technology, but we will see whether does it need it. Once again, Samresh shows how the vitreous is drained or sucked into the retractor, as you saw in the clinical example, with minimal impact on the posterior capsule tear, and the slow motion where the vitrectomy in this example is through the pars plana and irrigation is in the anterior chamber. There is minimal turbulence, unlike you saw in the previous one, and the tear is not impacted. How do I make this entry? Well, there are two approaches. One, which I use it, I'll show you first. But remember this anatomy once again. Try to do retinal surgeons tell us 3 millimeter, 3.5, and not nearer than 2 millimeter in this case. And this will vary depending upon the age, but generally this is a standard of pars plana. And this is, you can measure it if you're going to do the lens knife incision, but I use more often trocar. And what I do is I lift the conjunctiva and slant the trocar almost horizontally, if it's possible, in top of the sclera, between the conjunctiva and sclera, not piercing the sclera. So subconjunctival travel, a millimeter or so, and then I turn 90 degrees and aim the center of the globe, not the center of the pupil, not here, but center of the globe, say optic nerve. Direct that way, and then with a gentle movement, as you can see, like a screwing movement, you do that. This needs a little force, and therefore you may need to suture your cataract incision if it is bigger. Once you do that, that's not difficult. And then you can see the vitreous here, here in the anterior chamber and in the anterior vitreous face, which will be drained once again to pars plana. And notice the flow rate and the bottle height and the vacuum. The whole vitreous will be drained around the lens. It went from anterior chamber to the retractor, and then it just will disappear. So then it's not difficult to remove the vitreous from the anterior chamber, and then you can remove the trocar at the very end. Until that, you can plug it if it's not a valve trocar. And when you remove this trocar, and I really thank Manish Nagpal, who taught me this, Just make sure that you indent to prevent incarceration. And when you remove the retractor, also you keep it on a cut mode and not on a foot switch position irrigation alone. If you're going to do a lens knife or any other knife, and I use the paracentesis knife I have, which is 1.1 millimeter, you need to do peritomy and then measure the distance from the limbus, which could be 3 millimeter or 3.5, depending upon the age or your comfort. And then you introduce that knife. But I have an angled knife. A straight knife is a much better knife, and you can see that knife coming here at the end here. That I'm using that my finger is obstructing the view, but that's because of angle. But I would prefer a straight knife, less knife, and that is the distance, and that you need to suture that. Remember, this sclerotomy has to be sutured and 10-0 nylon or 9-0 whatever you want, and make sure that you suture very well. How does the retractor work? You can see that movement of the retractor here. They call it guillotine movement, forward, backward. And the typical recommended position is the first position, irrigation, cutting, retractor, and then aspiration. Always cut first before you aspirate. Although we have an option of cut IA, and that can be used to remove cortex or something like that, but please use cut IA mode rather than IA cut mode, because it will drag on the vitreous. And this is the aspiration first and then vitrectomy to illustrate that you can use it, but you can use IA handpieces also. You don't need to do that, but just to show you that you can. Now, when you perform vitrectomy, whichever way you want to perform, make sure you remove the vitreous very adequately behind the posterior capsule to produce a symmetrical removal and therefore a symmetrical support for the IOL in case you are using the remaining capsule to support the IOL. And what forms the scaffold for the IOL is not only the capsule where it is ruptured in the middle, but also the vitreous face. So I think you need to do that very well, understand, and then perform the vitrectomy. Now, if you do limbal vitrectomy, it's possible to remove the central vitreous from behind the posterior capsule quite well, but notice that there are pockets of vitreous. Even if you swap this vitrector from this end to this one, it's very difficult to remove these vitreous from underneath the peripheral posterior capsule on which the IOL is going to be supported, and you will have a asymmetrical removal of antivitreous, and this can tilt the lens. And when you see the patient on the post of time, you think the lens is very good, and you will expect the patient to be happy, but patient says, my vision is not that good because the tilt and aberrations that it produced. So symmetrical removal of the antivitreous phase is very important for IOL stability and quality. You can understand how effectively pars plana approach can remove the antivitreous in the area where the IOL, entire 6 millimeter of the IOL optic is to be supported with less chance of tilt. Once again, somebody showed this on a Miyake view. This is the limbal vitrectomy showing us that there are pockets left in the vitreous here in this region, which you cannot remove, which you saw it in animation. And if you already have an IOL and you have to do this, it can disturb the IOL haptics through limbal approach. Instead of that, if you do limbal, the pars plana, and this is pars plana vitrectomy, you can see, as you saw in animation, it's not difficult to remove and produce a symmetrical complete removal of the antivitreous through that area. So this is an example. A vitrectomy has been done in the central region, but having done everything, I'm trying to do more vitrectomy in that entire area so that when I use the IOL, and I'm lucky to use the capsule support in this case, but the point is that you need to do little more surrounding the tear area so that you produce a good, decent, symmetrical removal and produce a good scaffold. This is an example of a query posterior cataract, and it's always in the fallow eye of a chronic IOL or a multifocal that I have a problem. It's a law. And here is the cataract, no cataractor, but IOL got tilted. There is a torque happening because of the slow release. The surgeon was rather nervous. Nothing happened, luckily. And but notice here, there is some touch here, but capsule is intact. Now, to remove the vitreous, to remove the OVDs, the surgeon goes behind with the irrigation behind, aspiration in front of the IOL. And notice that weak spot now with the tilt of the IOL has resulted into the extension and posterior capsule rupture. Now, it's not a bad situation. IOL is already in the bag, and we were thinking that we should be fine, but always check it with triamcinolone. So we had this, because of multifocal, I just wanted to make sure that it's stable. And the moment I injected triamcinolone, I was a little bit disappointed that there was a vitreous coming from that tear around the lens, into the anterior chamber. So now we have the vitreous stuck into the incision. It's been caught inside the lips of the incision, and the vitreous somewhere here in the anterior chamber. So option could be to cutting with the scissors, which I would not recommend because it's very tedious and still you cannot remove it completely, or a limbal. When you limbal, this is an example where it will extend and enlarge the tear and the zonule. So I would, at least in this kind of situation, consider pars plana vitrectomy through the lens knife or a trocar. And once again, you will see that the vitreous here will be drained from the front into the around the same route that it came through into the retractor, and then we have to cut that vitreous which is caught in the incision. So this vitreous which is in the anterior chamber will be drained into the retractor quite effortlessly with minimal vacuum, so that you don't risk the posterior capsule remaining posterior capsule. And then you're then ready to do the anterior vitrectomy because it was caught into the incision. And here you are hydrating the incisions. And this is the same eye down the line. And you need to monitor it very carefully. And particularly if you have this kind of multifocality, and if you have the other instrumentation, it would be nice to ascertain how stable it is. But the best part is this particular eye, and I was lucky, I don't produce every time, no tilt and no aberration. So patient was happy, but that's not very common. Whatever you do, Limbal or a pars plana, once the capsule is open, always get the retinal surgeon check on the table if possible, or immediately on the same day or next day, and monitor them very carefully. One more time, a blunt trauma in the left eye a year ago, and dimness of visions since then, but worse for 2 weeks. And this is what he presented with. This is the one I showed you earlier, when to do vitrectomy. So I do this is the first incision made into the eye, and I'm planning the Trifan blue staining, and that's the standard technique. I'll be using a Helon 5 or Helon GV to do that, and I'm washing out the triamcinolone. But notice there is some little gap here, and that old trauma. I asked the anesthetist, is there a history of trauma? Because I have forgetfulness. And yes, there was a trauma some time ago, and that gave me a signal. So at that stage, I had to use the triamcinolone, and I noticed that there was a vitreous coming from that gap into the little incision already, and now I have a white cataract. What do I do? If I start doing cataract surgery, it will extend more. So this is something I will not recommend to most of you who are not very familiar with pars plana approach, but if you are, it will do a trick and will change the outcome entirely, as you will see now. So what I'm now planning, and my aim is to disconnect, sever the connection of these vitreous, which is caught into the incision, from the main body of the vitreous. So I don't know whether you can see that, but there will be some indication of a metal there. I'm more posterior away from the posterior capsule so that I don't rupture the posterior capsule. And you can be, and the Retractor is so good that it will sever the connection from the anterior vitreous to the posterior. And you can see that under the incision, and you will see the tag getting free in a minute. You can see that the tag now is free from the back of the vitreous. And now I am very happy. Now I can address it and remove it. And now I can proceed as I would have done earlier. So that's what it is. And I did that very well. And I can show that later on, but that's okay. I don't have that. But I put a Sioni ring there and then did the IOL in the bag. Now I'm showing you the dense cataract, not to show off, but it is possible to remove the dense cataract also. And this is the dense cataract I picked up for the time's sake from the time that we ruptured the capsule. The dense fragment is visible. My bevel is down. I'm not worried about that part here, that the vitreous, because I've done pars plana vitrectomy, and I'm able to remove this dense cataract easily with that. And this is the early part of that procedure where when I had the same eye, I took it forward and showing that the vitreous was removed from the chamber and severed the connection of that thing. And now I'm able to remove these fragments at a time. So you can do that and remove that without fearing of lens dropping, because there is no vitreous and the flow rate is only 18, low bottle height and sufficient vacuum. Even with the bevel down, it's not going to attract the vitreous because we have done sufficient anterior vitrectomy. So you don't need to do this, and it may not work every time. But the point I want to make is that if we had done good adequate vitrectomy, removing vitreous from area of your work, and also a little bit of the anterior vitrectomy, however limited it could be, it is possible to remove the remaining lens material. The amount of material or density generally doesn't matter if you've done a good vitrectomy. But remember the flow rate, 12 C flow rate, I use it for phaco, or 14, 300 vacuum, or the low IOP. This 30 means 52 centimeter bottle light, but high energy. So this is just to tell you, and this is the same eye. I've done that sufficient removal, but notice the iris chafing. Because of density, I burned the iris, and that's the price I had to pay for that. My retinal colleague was handy, and he checked it. Everything is fine. And then we retracted the iris, and to our surprise, pleasant surprise, there was sufficient capsule, and then we introduced the 3-piece IOL there, and then this is the end picture, which is quite satisfactory in that dense cataract. So how do I adapt? This is all right to show the videos and talk about it, but I've done one or two, and I'm not very confident. So I think first thing is to accept this concept. That concept is that pars plana is something you need to try. If you believe that concept and convinced, you will try the next step. And next step is to interact with vitreoretinal surgeon, your colleague. If you don't have in your place, talk to them, make friends, go to him once he does some pars plana entries, see the videos, and observe some of these things if you're lucky to see the posterior capsule. Now, therefore, the road to safety, I believe, is something which is important. Many of us have taken it, and I'm very happy that more and more people are joining on this path, which some of our stalwarts have started, and we all are in this, taking this path of this. But I just want to, with the time I have, I might show you some of these cases that I just skipped earlier, hopefully now. All right, so I think that should be the end. I can keep showing more, but I think that's the message is that we need to do vitrectomy, and whatever the option, make sure that you remove it completely. Use triamcinolone, closed chamber technique, and appropriate parameters. Now, for the IOL, what will you do? You have an option. You can have the ciliary sulcus fixated treatment if you have sufficient capsule, but generally speaking, many times you won't have that. So you have an option of transcleral fixation using various grades of Prolene from 10O to 5O Prolene of different lenses, and suture this with this Prolene or Gore-Tex, which I like Gore-Tex, and we published 100 eyes of Gore-Tex suture in AJO, American Journal, some time ago, and it's good because they don't disintegrate. But I believe the better technique is intrascleral fixation, and thanks to Gabor Sherian, Dr. Agarwal, and his team, which includes Priya Narang, intrascleral fixation has caught up correctly, and that's a very good concept. But lately, there is a further improvement, and I call it a refinement in some sense, Yamani technique. I like that Yamani technique. So whatever the technique you like, transcleral, intrascleral fixation, and I believe intrascleral fixation has an advantage, but that's a debate, and you can do that. I believe in intrascleral fixation, whatever that is. That IOL option is something we need to consider depending upon your experience. You can do it primarily on the time of the surgery or postpone it and refer it to the person who is doing it, or do it later on when you settle down, check the eye, and 3 months down the line, the eye heals well. So that's where the thing, and when you do the secondary implantation, whatever the technique, please, if possible, keep the retinal colleagues, because at that time, you need to assess the peripheral retina for a potential retinal break. You really need to do a decent vitrectomy, at least a core vitrectomy in these procedures. And I find many times that the cataract surgeon does him or herself alone, which may be okay for few selected surgeons. But generally, I strongly recommend to manage these cases in a planned fashion with the retinal colleagues handy or at the same time, so the patients are safe. So that is what I wanted to share. For a cataract surgeon, it is not difficult to learn. It is more of our mindset than the actual skill. If you can do a cataract removal, there's nothing more difficult than a cataract surgery. Anti-vitrectomy is not as difficult as the cataract surgery itself. So thank you so very much for your patient hearing.